Good afternoon, dear colleagues. I'm Ramin Tadayunei from Paris University, and I would like to welcome you to this Roche-sponsored Faricimab DME Symposium. As the president-elect of EURETINA, I also welcome you to EURETINA, and I also apologize that the entrance to here was so complicated. We have points to improve. So some other colleagues are still coming in, but we have to begin to be able to finish on time. So take your seat as soon as you can. Some disclaimers. So this is a scientific meeting sponsored by Hoffmann Roche, and it's intended to health professionals outside the United States, and you have all the details in this slide if you want to read it. So this is the European label for faricimab. Maybe I will show you the recommended posology and the summary here. So here you have the recommended posology, which is Q4 for the first loading dose, and then treat and extend an individualized approach for the remaining of the treatment. So here the panel. So I'm really honored to be here with a high-level panel and speakers. Paul Mitchell from Australia, Vas Sada and Nancy Holcamp from US. I'm sure you know all of them. You have all the details of our affiliation also in this slide. Here are disclosure on our commercial relationship and for who we are consultant or we are helping. Some housekeeping. So of course, please put your mobile phone on silent mode. And please submit any question that you have to the panel via this link. So I let you just use your phone to have this link, and you can connect to rocheuretina.com and to be able to ask any question you want to our expert panel. You will have this link again later on the slides. So once you will go to the site, you will have these screens and you will be able to ask a question. Please don't forget to push send. Otherwise, if you don't send it, I will not receive it. So here our objective this afternoon. We want to explore the Ang2 VEGF-A inhibition pathway and to see what it improves in the anatomic control, but also in terms of extending the durability of the disease control in our patients. Here our agenda, so we will quickly go to the presentation, and at the end we will have a panel discussion, but we will also have a very short Q&A after each presentation. So as soon as you have a question, please don't hesitate to send it so we can include in between presentation too. So I think here at EURETINA as an expert space, everyone knows that DME is a problem, not only because it affects many people in the world, more than 18 million people, and it's not going to decrease despite a better control of diabetes, because the diabetes is increasing, the number of people that are suffering from DME is increasing. And we know also what's the unmet need in DME. It's the frequency of injection, the burden that have for everyone that end up with a suboptimal long-term outcome. So if we want to improve the result in the whole population, to improve the outcome, we have to give an answer to all this burden and the problems that our patients are referring to, and they are right to do so. So one of the ways is to use the Ang-type pathway. This is nothing new. It comes from the 90s, but you know the time between the discovery of a receptor and the pathway to a drug take times, and this is quite short, 30 years to have this, compared to some others. So at the beginning was just the identification of the pathway. As often, because cancer is a domain in which there is a lot of research, probably more than in ophthalmology still, and it was in tumors that its role was shown, and then in inflammation, and finally it appears to be an important pathway in the retinal disease too. Because in the retina, you know, as usual in biology, when you have a gas pedal, you have also a brake. So the VEGF is the gas pedal. When you put VEGF, it increases the exudation, the opening of the broad retinal barrier. And the Tie2 usually is the brake. So when Ang1 connect to Tie2, so then it's some kind of brake. It's close the broad retinal barrier and decrease the exudation. But in disease, what happens is that Ang1 is replaced by Ang2, which take the brake out, and then you will have the opening of broad retinal barriers and angiogenesis that is fully effective due to VEGF. So it makes sense that you act in two of them, as also in human vitreous sample, it has been shown that in parallel to VEGF increase, there is an increase in Ang2. So at the same time that the biology is pushing the gas pedal, it taking out the brake. And if we want to counteract that, we have to act on the two sides too. And that's the role of faricimab, which on one side inhibit the VEGF-A, on the other side it inhibit Ang2 to allow Ang1 to push the brake and stop the disease. This has been studied in different diseases since 2020. We have all these studies that you can see here in DME, in neovascular AMD, and in RVO. And in DME, we had the Yosemite and Rhine study, which are the largest studies that has been done in DME area. And after that, we had a long 4-year total follow-up with RUN-X that will give us also very long-term information. So a lot of patients, very long-term information. That's the right way to have the maximum information to use this drug in the best way in our patient. There are Roche-sponsored studies in real life, and you have the list of these studies and where they are done. And they have been, of course, independent studies also that give us a lot of information about how effective this double pathway inhibition is. Indeed, the drug is used in real world. Now there is more than 1.2 million vials distributed in the world, so that's a huge experience. And since this enormous use of the drug, there is still a very favorable benefit-risk profile because nothing unexpected was reported since it's in use. So we'll go to the dual pathway inhibition with faricimab, how it changed the treatment paradigm, and what are the outcomes in clinical trials and real world. Again, please submit your questions here. I'm sure you don't have questions for me, but for the next presentations. So I give now the podium to Paul Mitchell for the next presentation. Paul, please.